Your creatinine result came back. The number was high. Maybe your doctor's face changed when they read it. Just for a second, just enough for you to notice. But here's what almost no one is told. A man walked into a hospital 2 days ago with a creatinine of 7.1. He walked out with a creatinine of 0.9. His kidneys were never permanently destroyed. The number moved because one specific thing changed. And the principle behind that change applies to your situation too. Here is the answer right now, no waiting. Creatinine is not a verdict. It is a waste product. Your kidneys are supposed to clear it the way a car engine produces exhaust and the pipe vents it out. When something blocks the pipe, the exhaust backs up and the gauge reads dangerous. Remove the block and the gauge drops, sometimes within hours. In the case of that 7.1, the block was a physical obstruction in the urinary drain. The number was 7.1 on a Tuesday. By Thursday morning, it was 0.9. That is not a medical miracle. That is a kidney doing exactly what it was built to do, the moment it was allowed to do it. For most people watching this, the block is different. It is not a physical drain backup. It is a slower, quieter kind of load. Too much protein hitting the filter, blood pressure pushing through it at the wrong angle, sodium pulling water in the wrong direction. The number does not drop in 48 hours with those loads. It moves over months, but it moves. And by the end of this hour, you will know which kind of load is behind your number and the specific levers for each. You are in one of two situations right now, and you cannot tell which from the outside. Door A is the conventional explanation. Your creatinine is elevated because your kidneys are damaged, and elevated is simply where it lives now. The doctor noted it. You are watching it. That is the plan. Door B is the overturn. Your creatinine is elevated because your kidneys are working against a load they cannot fully clear. And some of that load is removable. One kind removes in 48 hours. Another kind removes over months. You do not know which door is yours until you understand what is raising the number. And that is what this hour is for. You will know 3 things by the time this is done. You will know what creatinine actually measures and why the number is more movable than you have been led to believe. You will know the specific dietary and lifestyle changes that have documented effects on that number for someone at stage 3. Not generic advice, specific numbers and timeframes. And you will know the exact sentence to bring to your next appointment that gets your creatinine context documented in your chart, so it travels with you. If you have your last kidney lab result written down or nearby, get it now. If not, picture the number your doctor read out. Hold it in mind. That number is what we are working with today. You know the room. A clinic off the highway near the villages, one of those low buildings with the parking lot that fills up by 8 in the morning. You are in the chair with the paper printout in your hand. The number is right there, circled. The doctor steps in, runs a finger down the page, pauses at the creatinine line. This is significantly elevated. We'll need to watch this closely. And he is already reaching for the door. You are thinking, watch it. That is the whole plan. Watch a number that size. But you do not say it, because you do not have the words yet. So you drive home on Route 41, and that night, somewhere between midnight and the ceiling, the question comes back, the one you did not ask. By the end of this hour, you will have the words. Which of these 3 is closest to where you are right now? You got a result recently. Maybe the first one that surprised you, maybe the first one that used the word elevated. You are Googling at odd hours. You want to know whether the number means what you think it means, and whether your life just changed in a way you cannot undo. The segment on what creatinine actually measures is going to answer the question you have been afraid to ask directly. Or you have been managing this for a year or more. You are doing what you were told. The medication, the follow-ups, and your number has not moved the way you expected. Maybe it has crept up, not down. You feel like you are doing everything right and the system is not explaining why it is not working. The dietary blueprint in the next segment is going to give you the specific levers nobody handed you in a 7-minute visit. Or your number is where your team wants it, and you are here to understand the mechanism. You are curious, not scared. You want to know why what you are doing works, and whether there is anything you have not tried yet. The mechanism section is going to give you exactly that depth. No matter which of the 3 you are, the number your doctor reads off the page works the same way. And it starts with something almost no one has explained. Let's start with the man and the number. He was an older gentleman, late 60s, long history of diabetes. He came to the hospital because urine had essentially stopped, not slowed, stopped. And the creatinine on his blood panel read 7.1 milligrams per deciliter. To put that in context, normal creatinine for a man his age is somewhere between roughly 0.7 and 1.3. A reading of 7.1 sits in territory that, on paper, can indicate severe kidney failure, the kind of number that can prompt a conversation about dialysis. It did not, because the team did something before they reached any conclusion. They ordered an ultrasound, and the ultrasound told a completely different story. But before we get to what it showed and what happened in the 48 hours that followed, you need to understand what creatinine actually is. Because the number that frightened this man's family, the number that may be sitting on your own lab report right now, is not measuring what most people think it is measuring. Creatinine is a waste product. It is produced continuously by your muscles as they do their normal work, the same way a car engine running produces exhaust. Your kidneys filter creatinine out of the blood and send it into urine. When they are doing their job well, the level in your blood stays low because the pipe is venting the exhaust fast enough. When something slows the clearing, when the pipe is blocked or narrowed or overwhelmed, creatinine backs up in the blood and the number on the report climbs. Here is the thing that most explanations skip. The creatinine gauge does not know why the pipe is struggling. It just reads how much exhaust is backing up. And there are several very different reasons the pipe can struggle, reasons that have completely different implications for what you do next. The first reason is permanent damage to the kidney filters themselves. That is chronic kidney disease, CKD. The filters, which are called nephrons, are damaged or lost over time. The kidney cannot clear waste as efficiently. Creatinine accumulates. This is the story most people think they are reading when the number goes up. The second reason is physical obstruction, something blocking the flow of urine on its way out of the kidney downstream of the filter. The filters are working, the pipe is running, but somewhere below them, the drain is blocked. Backed up pressure travels upward. The kidney, still capable of filtering, essentially cannot send its output anywhere. So creatinine accumulates, not because the filters are broken, but because the drain is blocked. The third reason, and the one most relevant to the dietary blueprint coming in the next segment, is load. How much waste the filter is being asked to process. Dietary protein, the protein from the food you eat, generates creatinine and other waste products as your body breaks it down. The higher the protein load, the more exhaust the engine produces. A kidney working at reduced capacity, say stage 3, which means roughly 30 to 59% of normal filtering function, can handle a moderate load. Push that load higher than it can manage, and creatinine rises, not because the kidney got worse, but because the intake exceeded what the remaining pipe could vent. These are not the same problem. They do not have the same solution. And your creatinine number, sitting on that lab printout, cannot tell you which one you are dealing with. Now back to the man with the 7.1. The ultrasound showed something straightforward. Both kidneys were swollen. A finding called hydronephrosis, which means fluid is backing up into the kidney because it cannot drain properly. And the bladder still held 575 milliliters of urine that had not emptied, even after the patient had tried. To put that in perspective, a normal post-void residual, the amount of urine remaining after urination, is under about 100 milliliters. He had nearly 6 times that amount sitting in his bladder, unable to exit. This is bladder outlet obstruction. The kidney was not failing, it was blocked. The team placed a catheter, a thin tube that bypasses the obstruction and allows urine to drain. Within the first hours of placement, 1,500 milliliters of urine drained immediately. The backed-up pressure on the kidneys released. The swelling began to resolve. And the creatinine, which had climbed to 7.1 because the kidneys had been functioning in a closed system with nowhere to send their output, began to fall. 2 days later, 0.9. This is not a unique case. Published research on post-renal acute kidney injury, the medical term for kidney dysfunction caused by a downstream obstruction rather than damage to the kidney itself, consistently shows that when obstruction is the cause and the kidney tissue itself has not been permanently scarred, creatinine can recover to near normal levels within 24 to 72 hours of decompression. The key variable is how long the obstruction has been in place. Short duration obstruction with an otherwise intact kidney, rapid, often complete recovery. Prolonged obstruction over weeks or months. The pressure damages the tissue and recovery is partial. This distinction matters enormously. Not every elevated creatinine is a permanently damaged kidney. Some elevated creatinines are a temporarily blocked pipe, and blocked pipes, once cleared, allow the gauge to drop back to where it belongs. Now, what causes this kind of obstruction? And why does it matter specifically for the people most likely to be watching this channel? The most common cause of bladder outlet obstruction in older men is an enlarged prostate, a condition called benign prostatic hyperplasia, or BPH. The prostate is a gland that sits just below the bladder. As it enlarges with age, it can compress the urethra, the tube through which urine exits the body. The flow narrows, the bladder cannot fully empty. Over time, the residual volume grows, the back pressure climbs. The second cause, and the one that received particular attention in this case, is diabetic cystopathy. People with long-standing diabetes can develop damage to the nerves that control bladder function. The same process that causes diabetic neuropathy in the feet, the burning and numbness that develops when nerve signals become unreliable. In the bladder, that nerve damage means the signals that tell the muscle to contract and push urine out become weak or inconsistent. The patient may feel little urgency. Urine accumulates silently, sometimes in very large volumes, without the normal warning sensation. And because there is no dramatic symptom, no severe pain, no acute event, the accumulation can persist for long enough that creatinine climbs to a level that looks, on paper, like kidney failure. This combination, yet an older man, diabetes, slowly accumulating urine, a creatinine that reads catastrophically high, is not rare. And the diagnostic step that separates it from actual kidney failure is a single ultrasound with measurement of post-void residual. One test, low cost, widely available, and it can distinguish between a kidney that is structurally failing and a kidney that is being choked by a fixable downstream problem. The takeaway for anyone watching this who has seen a sudden significant rise in creatinine, the first question is not just how damaged are the kidneys. The first question is there a downstream obstruction that is being missed? An ultrasound answers it. And if obstruction is the answer, the creatinine that looked like a verdict may turn out to be a problem that resolves in 48 hours. What about the creatinine on your lab report right now? The one that has been climbing slowly over months or years in the context of diagnosed kidney disease. That is a different story, not obstruction, load. And that is what the next segment is for. Before we go there, this video does not diagnose your kidney situation. The sudden creatinine spike and the obstructive mechanism described here apply to a specific clinical scenario, a rapid rise, often with reduced urine output, in someone with risk factors for obstruction. If your creatinine has been rising slowly over time in the context of known CKD, obstruction is not the likely explanation. What this segment gives you is the understanding that creatinine is contextual. It rises for different reasons, and those reasons require different responses. That understanding is what you bring to your next appointment. If you are managing kidney disease at any stage, do not change, stop, start, or modify anything about your diet or your medications based on this video alone. What we are doing here is giving you the framework for a better conversation with your kidney team, not a prescription. So that is the before, and the dramatic case that proves the principle. The kidney is not always broken. Sometimes it is blocked, and sometimes it is simply overloaded. The question is, what overloads it over months, and what specifically you can remove? The mechanism is more precise than any general advice you have been given, and once you see it, the dietary blueprint that follows is going to make exact sense. There is one principle behind both scenarios in this video. Same kidney, same gauge, same exhaust. Different reason the pipe is struggling, different timeline for clearing it, but the same fundamental logic. Go back to the exhaust pipe. Your muscles produce creatinine continuously. It is a byproduct of normal muscle metabolism, the same way an engine running produces exhaust. That exhaust has to go somewhere. In a healthy kidney, it goes through roughly 2 million tiny filters, 1 million per kidney, each one called a nephron. The creatinine passes through the filter into the urine, and the urine carries it out. The blood level stays low because the output matches the production. Two things can break that balance. Production can go up, or clearance can go down. In the obstructive case, clearance went to nearly zero because the output had nowhere to go. The filters were working, the exhaust was passing through, but the pipe downstream was sealed. Remove the seal, insert the catheter, and the backed-up exhaust clears rapidly. The kidney had never stopped filtering. It just had nowhere to send the result. In the dietary case, the problem is different. The filters are partially damaged. This is stage 3 kidney disease. The pipe is narrower than it used to be because some of the nephrons have been lost. The pipe still works, but it cannot handle the same volume it once did. And if the production side, the amount of creatinine the body generates, stays at the level of someone with 2 fully functioning kidneys, the narrower pipe backs up. Here is where dietary protein enters the picture. When you eat protein, a chicken breast, a steak, a glass of milk, a protein shake, your body breaks it down. That breakdown generates waste products. One of them is urea, which your kidneys also filter. Another is creatinine, generated from the creatine that protein metabolism produces. A high protein intake does not raise creatinine as dramatically as obstruction does, and it does not raise it in a matter of hours. But over weeks and months, a protein load that exceeds what your remaining nephrons can efficiently clear will result in a creatinine that runs higher than it would otherwise. The engine is producing more exhaust than the narrowed pipe can vent. The published evidence on this is not emerging. The 2024 Clinical Practice Guideline from the Kidney Disease Improving Global Outcomes Group, the international body that sets the standards for kidney disease management worldwide, states explicitly that dietary protein intake is a non-GFR determinant of serum creatinine. That is guideline language for the protein you eat affects the creatinine number independently of how much kidney function you have. For adults with stage 3 through stage 5 kidney disease who are not on dialysis, the guideline recommends maintaining protein intake at approximately 0.8 grams per kilogram of body weight per day, and explicitly flags high protein intake above 1.3 grams per kilogram as a risk for progression in anyone with active kidney disease. Let's make that number real. If you weigh 170 pounds, that is approximately 77 kilograms. At 0.8 grams per kilogram, your target is roughly 62 grams of protein per day. A typical grilled chicken breast contains around 25 to 30 grams. A large steak can contain 50 to 60. A standard protein shake can add another 25. A person eating what the American diet considers a moderate protein intake, 2 substantial protein servings per day plus dairy, can easily be running at 90 to 110 grams daily without realizing it. That is a pipe working harder than it needs to. Reducing to the evidence-based range does not undo kidney damage. The pipe is still narrowed, but it reduces the production side of the equation, less exhaust for the same pipe. And the creatinine that was running artificially high because of load starts to find a lower, more accurate baseline. This is not the kidney getting better. It is the creatinine number becoming more honest about where the kidney actually is. The second major dietary lever is sodium. Sodium, salt, does something specific in a kidney under stress. When the kidney retains excess sodium, it holds water with it. That extra fluid expands blood volume. Expanded blood volume raises blood pressure, and elevated blood pressure, transmitted into the kidney's filters, increases the internal pressure those filters are working against. The same mechanism that makes ACE inhibitors and ARBs useful kidney protective medications, they reduce that internal filter pressure, is the mechanism that makes sodium restriction important. You are reducing the pressure load on the filters from the dietary side. Published clinical trial data on sodium restriction in stage 3 and 4, CKD, shows measurable reductions in blood pressure and in the amount of protein leaking into the urine within weeks of implementing a low-sodium approach. The 2024 KDIGO guideline recommends keeping sodium intake below 2 grams, that is 2,000 milligrams, per day for people with kidney disease at any stage. For context, the average American consumes approximately 3,400 milligrams per day. The gap between current intake and the evidence-based target is not small. Where does sodium hide? Not primarily in the salt shaker. Roughly 70% of dietary sodium comes from processed and packaged foods, canned soups, deli meats, frozen meals, restaurant food, bread, and condiments. The actionable is not seasoning differently at the table. It is reading labels on everything packaged, choosing fresh meat over cured or deli preparations, and cooking from ingredients rather than from products. Now, the dietary blueprint for creatinine reduction. This is stage-specific for CKD stage 3 pre-dialysis. These targets do not apply universally. They apply to this stage. The rules change at dialysis, when protein needs reverse direction entirely, and your kidney team needs to confirm what is right for your current labs. The 3-lever dietary blueprint for stage 3 CKD. Lever 1 is protein. Target: approximately 0.8 grams per kilogram of body weight per day. Avoid high protein intake above 1.3 grams per kilogram. Take your weight in pounds, divide by 2.2, multiply by 0.8. That is your daily target in grams. Prioritize quality protein distributed across the day, rather than concentrated in one large meal, which spikes the filtration demand. A palm-sized portion of protein at each meal is a reasonable working approximation. Lever 2 is sodium. Target: under 2,000 milligrams per day. Read every label. Anything above 500 milligrams per serving is high. Choose fresh over packaged. Flavor with herbs, spices, garlic, citrus, and vinegar, not with salt substitutes, which are almost always made with potassium chloride and can be genuinely dangerous if your kidney function is impaired or if you are on an ACE inhibitor, an ARB, or other medications that affect potassium handling. Lever 3, and this is the one most people do not know about, is the phosphate additive. This is different from the naturally occurring phosphorus in whole foods, which the body absorbs at around 40 to 60%. Inorganic phosphate, added to processed foods, fast food, and dark sodas as a preservative and flavor enhancer, is absorbed at close to 100%. Retained phosphate puts additional stress on the kidney's mineral handling function. The way to spot it: look at the ingredient list, not the nutrition panel, for anything containing the letters PHOS. Phosphoric acid, sodium phosphate, calcium phosphate, dicalcium phosphate. These are additive phosphates, and avoiding them is a low-effort, high-impact move for anyone in stage 3 or beyond. What is the expected timeline on the dietary side? Published research on low-protein diets in CKD stage 3 to 5 shows measurable effects on creatinine and kidney function markers within 3 to 6 months of consistent dietary change, not weeks, months. The reduction is not dramatic in the way the 7.1 to 0.9 case is dramatic. You are not reversing kidney disease. You are removing an unnecessary load from a pipe that does not have the spare capacity to absorb it. The number moves because the production side comes down. And the kidney, relieved of that extra burden, may show an eGFR, the estimated filtering rate, the percentage of your kidney's original capacity that is still working, that is slightly higher than it would otherwise be, simply because the creatinine it is clearing reflects a more appropriate intake. This is the honest, bounded version of the hope. The pipe does not get wider, but you can stop overloading it, and that shows up on the lab report. Now, here is the physical action request. Stop for just a moment before the next segment. Think about what you ate yesterday. Estimate the protein, breakfast, lunch, dinner, snacks. Think about how much of it came from a package, a can, or a restaurant. You do not need to calculate it precisely right now. Just let the rough picture form, because the next segment is going to explain why the specific numbers in this blueprint, the 0.8 grams, the 2,000 milligrams, have never been handed to you in the specific form you just heard them. You probably have a version of this question forming right now. If this is this clear, if the protein target is in the KDIGO guideline, if the sodium restriction is published evidence, if the ultrasound that separates obstruction from damage costs almost nothing, why hasn't your own kidney doctor walked you through this? The answer is not what you expect. Here is the question sitting in your head right now, and it is a fair one. If the ultrasound that separates obstruction from kidney failure is standard practice, if it costs almost nothing and takes 20 minutes, why wasn't it the first thing ordered when the creatinine hit 7.1? And if the protein target for stage 3 kidney disease is written into an international guideline, if the sodium limit is published clinical evidence, if the KDIGO recommendation that dietary protein intake affects creatinine was finalized in 2024, why hasn't your own kidney doctor sat across from you with a piece of paper and walked you through a gram calculation? The answer is not what you are expecting. And it is not the answer that makes for a satisfying villain. Your kidney doctor, your nephrologist, your primary care physician managing your kidney function, is almost certainly a competent, well-trained clinician who genuinely wants your numbers to move in the right direction. The explanation for why you have never received the specific, numbered dietary blueprint in segment 2 has nothing to do with negligence and nothing to do with indifference. It has to do with a structural problem in how medicine delivers information at scale. And understanding that structure is what gives you the ability to change your own outcome. Here is the structure. A standard nephrology follow-up visit runs approximately 12 to 15 minutes. In that window, your clinician is reviewing your labs from the last visit, adjusting medications if needed, checking blood pressure, reviewing symptoms, ordering the next set of tests, and documenting everything for the record. 12 to 15 minutes every 3 to 6 months. The math does not leave space for a detailed dietary counseling session, even when the clinician knows the evidence, even when they believe the protein target matters, even when they have the KDIGO guideline memorized. This is not a failure of individual intention. It is a structural constraint of how medical appointments are built and reimbursed in the United States. The average nephrology visit has not been redesigned to accommodate the 2024 KDIGO guidelines' expanded emphasis on dietary management because redesigning the visit structure requires systemic change, changes to billing codes, referral pathways, staffing models, and appointment length. Those changes happen on a timeline measured in years, not months. The research that shows protein restriction matters in stage 3 CKD has been accumulating since the 1990s. The guideline that formalized it in updated terms was published in 2024. The average nephrology practice has not yet operationalized it as a routine checklist item at every stage 3 visit. That gap between what the research shows and what reaches the exam room in a routine appointment is not a conspiracy. It is a lag. It is the normal, frustrating, well-documented lag between evidence publication and clinical implementation. Research on how long it takes for published evidence to reach standard practice consistently shows a range of 10 to 17 years for guideline-level recommendations to become routine clinical behavior. 10 to 17 years. The 2024 KDIGO guideline is 1 year old. You are sitting in that gap right now. Not because your doctor is wrong, because the system moves slowly, and the visit is short, and the dietary conversation, the one that would take 30 minutes to do properly, including the gram calculation, the sodium sources, the phosphate additive reading, the stage-specific adjustments, simply does not fit inside the structure that currently exists. Here is the second part of the pattern, and this one is specific to the obstruction story. A suddenly elevated creatinine in an older adult with kidney disease triggers a specific diagnostic pathway that runs fast. The clinician sees the number, compares it to the last result, and begins working through a mental checklist. Is this dehydration? Is this a medication effect? Has something changed in the blood pressure management? Is this progression of the underlying disease? That checklist is built on pattern recognition, the accumulated experience of seeing hundreds of patients with elevated creatinine and knowing statistically what the most likely causes are. Progression of existing kidney disease is near the top of that list. Bladder outlet obstruction causing a creatinine this high in a patient with known CKD. That pattern is less common, and the clinical picture can be subtle when the patient has diabetic nerve damage that suppresses the sensation of retention. The clinician who sees a creatinine of 7.1 in a patient with stage 3 CKD and diabetes is running on a pattern that says, "This looks like accelerated progression." The further question, but wait, has urine output changed and has anyone checked a post-void residual, requires stepping outside the dominant pattern. That step does not always happen in a 12-minute visit when the more common explanation is staring off the page. This is not a moral failure. It is the way pattern-based thinking works under time pressure. It is accurate most of the time, and the times it misses, and the times obstruction is behind a number that looks like progression, are the times that a simple ultrasound would have changed everything in 48 hours instead of managing a number that never needed to be managed. The someone who brings the less common pattern into the room, who says, "I've read that post-void residual can be the explanation for a sudden creatinine spike in older patients with diabetes. Has that been ruled out?" That someone is not being difficult. They are doing exactly what the evidence supports. They are participating in their own care at the level the evidence requires. And that someone is you. The only way the pattern updates for your specific situation, before the guidelines fully penetrate routine practice, before the visit length expands, before the dietary counseling slot is built into every stage 3 follow-up, is if someone brings the new information into the room. The someone is you. Now you understand why the before state persisted, for the dramatic case and for the slower one. The question is what you do with it. And the answer is a very specific conversation. Starting with one sentence your doctor can put in your chart and track from that visit forward. This is the segment everything has been building toward. Not a general suggestion to discuss diet with your team. The literal words, the specific tests. The chart documentation request that makes this visit count, not just for today, but for every appointment that follows. There are 2 conversations in this segment, and one for each scenario. They are related. You may need both. Conversation 1. If your creatinine rose suddenly. This applies if your creatinine jumped significantly, by more than 0.3 milligrams per deciliter in a short window, or if it reached a level that alarmed your doctor. And the explanation offered was simply progression or we'll watch it. Before your next appointment, write down these 3 things: the date of the elevated reading, the number itself, and whether your urine output changed around that time, whether it seemed reduced, whether you were straining, whether you felt any sense of incomplete emptying after urination. You do not need to know the medical term for any of this. You just need to have noticed it and written it down. The opening sentence is this: I've been reading about causes of sudden creatinine spikes in people my age and my situation, and I came across something called bladder outlet obstruction and post-void residual. Has that been ruled out in my case? That sentence does 3 things. It names the specific mechanism. It uses the clinical terms, bladder outlet obstruction, post-void residual, so your doctor hears immediately that this is an informed question, not a general worry. And it asks for a specific confirmation, not a general reassurance. The 3 responses you will likely receive. Response 1. Your doctor confirms that obstruction has been ruled out and explains how. This is the best outcome. You now know what you are dealing with and can focus entirely on the dietary management conversation below. Response 2. Your doctor orders an ultrasound to check. This is the correct clinical step. An ultrasound with post-void residual measurement is the standard diagnostic tool. If the PVR, or post-void residual, the amount of urine remaining after urination, comes back above 150 to 200 milliliters, that is clinically significant and warrants further evaluation. If it comes back normal, again, now you know. Response 3. Your doctor dismisses the question without a clear explanation. This is the moment to use the chart documentation request. Say this: would you be comfortable noting in my chart that I asked about bladder outlet obstruction as a possible contributor to my creatinine elevation and what we decided? That sentence does not escalate. It does not argue. It simply creates a record that the question was raised and addressed, which means it will be in your chart if a different clinician sees you, if you transfer care, or if the number rises further and the question needs to be revisited. A result that is not in your chart does not travel with you. Conversation 2. The dietary blueprint conversation. This is for everyone, for the sudden spike and for the slow creep. It is the conversation that translates the dietary blueprint from segment 2 into something your clinical record can track. Before the appointment, calculate your rough daily protein intake from the last 3 days. Write down the total and the calculation. Your weight in pounds divided by 2.2 multiplied by 0.8 equals your target in grams. Note the gap between your current intake and the target if there is one. The opening sentence is this: I've been looking into how dietary protein and sodium affect creatinine levels, and I'd like to try bringing my protein closer to the 0.8 grams per kilogram target that's in the current kidney disease guidelines. Can we document that I'm making this change and track my creatinine against it over the next 3 to 6 months? Walk through the 3 tests and markers you want tracked. The first is serum creatinine, the number you already have. You want it measured at the same time of day if possible under similar dietary conditions, so the trend is clean. The second is the urine albumin to creatinine ratio, the UACR. This is a urine test that measures protein leaking from the kidney filter. It is an early warning marker that often changes before creatinine does. If your protein load has been stressing the filters, the UACR may be elevated even when creatinine looks stable. If your dietary changes are working, the UACR is often the first number to improve. Ask for it by name. Can we also check a UACR, a urine albumin to creatinine ratio, at this visit if I haven't had one recently? The third, if your doctor is willing, is a cystatin C. Cystatin C is a filtration marker that, unlike creatinine, is not meaningfully affected by protein intake, muscle mass, or dietary habits. It is a cleaner read on actual kidney filtering capacity. And the 2024 KDIGO guideline explicitly identifies it as a confirmatory tool for cases where creatinine is an unreliable signal. The ask: would it be worth checking a cystatin C to get a baseline reading of my filtration capacity that isn't affected by my dietary protein? The do not do list for this conversation is short but important. Do not argue if the first response is skeptical. Skepticism is a normal clinical response to patient-initiated research. State the information, name the guideline reference, and move to the chart documentation request. Do not threaten to switch doctors or stop medications. These are not negotiating tactics. They are conversation enders that put your care at risk. Do not bring more than 2 questions into a single visit if the appointment is short. The creatinine context question and the dietary tracking request are a complete package. Save additional questions for the next visit. The keystone sentence, the one that makes this appointment count beyond today, is this: would you be comfortable noting in my chart that I asked about dietary protein and sodium as factors in my creatinine level, what target we agreed on, and that we're planning to track the number over the next 3 to 6 months against those dietary changes? That sentence is the reason this conversation becomes longitudinal rather than one time. The doctor can only protect a result they know is yours to protect. If the dietary change and its effect on your creatinine is not in your chart, it does not travel with you to the next visit, to a different clinician, or to a specialist referral. Once it is documented, it becomes part of the clinical story of your kidneys. And every provider who sees you can see that you tried this, what happened, and what the number did. You now have the research, the mechanism, the dietary blueprint, the conversation scripts, the specific tests to ask for, and the sentence that puts everything in your chart. There is one more thing. And it is the thing that makes all of this work not just at the next appointment, but at every appointment for the rest of your life. Sit back for a moment. Close your eyes if you want to. Picture this. It is your next kidney appointment. You walk in with 3 things in your hand: your last lab result, the creatinine number, the date, the context, your dietary log from the past 3 months. Rough, not perfect, but consistent. And the sentence. The doctor looks at the numbers. The creatinine has shifted, not dramatically, not the 7.1 to 0.9 kind of shift, but it has moved in the right direction. Or maybe it has held steady when it had been creeping upward. Either of those outcomes is meaningful. Either of them represents the pipe running at a more appropriate load. And the doctor looks up from the panel and says, "What changed?" You have the answer. I brought my protein closer to 0.8 grams per kilogram. I got the sodium under 2 grams. I stopped buying anything with phosphate additives in the ingredient list. 3 sentences, specific, numbered source to the mechanism you now understand. Not a vague, "I've been eating better." The exact levers and the evidence behind why you pulled them. That moment, the moment your doctor looks up from the panel because something moved, is not available to the version of you who left the last appointment with "we'll watch it" and did nothing different. It is only available to the version of you who understood what the number is measuring and made a specific documented change. Now picture the second future. 6 months from now, you are at a family dinner. A sibling, an adult child, a friend, someone who has also been told their kidney numbers are a little off. They mention it the way people mention these things, quietly, almost as an aside. The doctor said my creatinine was elevated. They want to watch it. You know that sentence now. You know what is behind it. You know the 3 questions that should follow it. Is there an obstruction? What is the protein load? Has anyone checked the UACR? You have the conversation. You hand over the gram calculation. You tell them about the salt substitutes that most people don't know are made with potassium chloride. You give them the sentence that gets the dietary change into the chart. That is not just information you have, that is a skill. It is transferable. It applies to every lab panel you will ever see. For yourself, for the people around you. Every number on that panel reflects a balance between what the body produces and what the kidney can clear. Creatinine, potassium, phosphorus, urea, all of them. The question behind every number is the same. What is raising the load, and is any of it removable? You are not someone who watches a number and waits for the next appointment. You are someone who understands what the number is measuring, which levers affect it, and what to say when you sit across from the clinician who is managing it with you. That is the identity this hour gives you, and it travels to every appointment from here forward. Can you actually lower creatinine naturally, or is that just something people say online? You can influence how high your creatinine runs within the constraints of your actual kidney function. The creatinine number reflects both filtering capacity and the load being placed on the filter. Reducing dietary protein toward 0.8 grams per kilogram of body weight per day, which is the recommendation in the 2024 International Kidney Disease Guidelines for stage 3 to 5 CKD, reduces the production side of the equation. Sodium restriction under 2 grams per day reduces blood pressure load on the filters, which also affects how efficiently the kidney clears waste. Published research on these interventions shows measurable effects on kidney function markers within 3 to 6 months of consistent change. The number will not drop the way it did in the obstructive AKI case. That was a blocked pipe being unblocked. This is a narrowed pipe being given a more appropriate load. The honest framing: you are not healing the pipe. You are stopping it from running harder than it needs to. What foods lower creatinine levels fast? No single food lowers creatinine fast. The dietary influence on creatinine works through 2 mechanisms: reducing the protein load that generates creatinine as a byproduct, and reducing sodium that drives blood pressure into the filters. Both work over months, not days. For stage 3 CKD specifically, the foods that support a lower creatinine load are lower protein options spread through the day. Egg whites rather than whole eggs for some meals, fish rather than large cuts of red meat, and plant-based protein sources where appropriate, though plant proteins in CKD come with their own potassium and phosphorus considerations that must be checked against your current labs and confirmed with your kidney team before changing anything. What does not belong in a creatinine-lowering approach: high-protein shakes or supplements, large red meat portions at every meal, and anything with phosphate additives in the ingredient list. This isn't a prescription. Your exact protein limit and your specific safe foods depend on your stage, your latest labs, and what your kidney team confirms is right for you. Why did my creatinine go from normal to high so fast? Does that mean my kidneys are failing? A rapid creatinine spike is not the same as end-stage kidney failure, and the speed of the change is actually important clinical information. Permanent kidney damage from chronic disease tends to cause a gradual, slow upward slope over months or years. A creatinine that spikes quickly, in days to weeks, more often indicates something acute and potentially reversible: dehydration, a medication effect, or a downstream obstruction like the bladder outlet problem discussed in this video. The most important question to ask when this happens is whether urine output has changed. If it has, If urine is significantly reduced, or if there is any sense of incomplete emptying, an ultrasound with post-void residual measurement is the first diagnostic step. Rapid creatinine spikes deserve an explanation, not just monitoring. You are entitled to ask what is causing the change, not only what the number is. Is there a connection between creatinine and what I eat every day? Yes, and it is more direct than most people are told. Creatinine is generated from creatine phosphate, a molecule involved in muscle energy metabolism, and from the amino acids in the protein you digest. A high-protein meal raises creatinine production for several hours. Over days and weeks of consistently high protein intake, someone with reduced kidney function, fewer nephrons to clear the load, will run a higher creatinine baseline than someone with the same kidney capacity eating within the evidence-based protein range. This is not a small or theoretical effect. It is explicitly named in the 2024 KDIGO-CKD guideline as a non-GFR determinant of serum creatinine, meaning your food intake affects the number independently of how much kidney function you actually have. If your creatinine was measured after a day of unusually high protein intake, the number may be higher than your true functional baseline. Bringing this to your appointment, I want to make sure my creatinine is being tracked under consistent dietary conditions, is a specific, warranted ask. What is your angle here? Why are you telling me this? That is the right question to ask, and it deserves a straight answer. This channel exists because the gap between what kidney research shows and what reaches the average patient in a 7-minute visit is wide and consistently closing in the wrong direction. Nothing being discussed here is secret or suppressed. It is in published guidelines and peer-reviewed journals. The problem is not access to the information. It is the translation of that information into something specific enough to act on and bring to an appointment. That is what this hour is trying to do. There is no product being sold, no supplement being recommended, no program that unlocks more. The payoff is the conversation you are now equipped to have. If it helps, share it with one person who is navigating their kidney numbers and has also been told to wait and watch. Here is the structural pattern behind everything in this video, and it applies well beyond creatinine. Every number on your kidney panel, creatinine, potassium, phosphorus, urea, reflects a balance. On one side, what the body produces, what comes in through the diet, what the blood delivers to the filter. On the other side, what the kidney can clear at its current functional capacity. Most clinical conversations focus exclusively on the right side of that balance. The kidney's capacity, the eGFR, the stage, the nephron count. What is the damage? How much function remains? How fast is it declining? The left side, the load, is under-discussed. Not because it does not matter, because it takes time to explain, and the appointment is short. Every dietary change, every sodium reduction, every protein adjustment is acting on the load side of that balance. You cannot add nephrons back. You can reduce what you ask of the ones that remain. That is not a small thing. That is the mechanism behind the difference between a creatinine that creeps steadily upward and one that stabilizes. Between a pipe that is asked to vent more than it can and one that is given an appropriate load. The skill you carry out of this hour is the habit of asking both sides of the question. Not just what is the number, but what is raising the load and is any of it removable? That question applies to your next creatinine result. It applies to your potassium. It applies to your phosphorus. It applies to every panel you will receive from here forward. That is the transferable skill. Not a single dietary change, not a single appointment conversation. The habit of reading a number as a balance and knowing which side you can actually move. You came into this hour with a number on a piece of paper, a number that someone read out, noted, and passed on, and that has been sitting in the back of your thinking ever since in the way that health numbers do when they are not fully explained. You are leaving with something different, not a guarantee, not a cure. Something more durable than either of those things, the understanding of what that number is actually measuring, and the specific levers on your side of the equation. The pipe and the load, the gauge and what it reflects, the sentence that gets it into the chart. Write that sentence down before your next appointment. Take it in the room with you. And if someone in your life, a spouse, a sibling, a friend who mentioned their kidney numbers quietly over the phone is sitting with the same piece of paper and the same unexplained number. Share this with them. You already had the kidneys you have. What you have now, that is new.